invite Dr. Lahane for his talk, especially, visibility is very, very important for certain corneal diseases. If that is how you can make the successful cataract surgery without any complication. Thank you.
Thank you, Kamalji Singh sir, SP Singh sir, Ruchi and Ragini. Good morning to all. My topic today is SICS in the corneal diseases. So SICS can be performed in any type of problems. So there is no any financial disclosure. Now you know the corneal opacity with the cataract. So normally there are challenges in the management. You get the challenges. Then there are the visualization of the glow is limited. Guarded visual prognosis is there in the patient. IOL calculation is very difficult because the surface of the cornea is different. Then may need the corneal this intervention sometimes. Then if you see the cataract, if you see, so there are so many I can say challenges in the can see the keratoplasty also followed by the cataract or earliotomies, all other thing, cataract with the keratoplasty, triple procedure we do. So these are the problems that happens. Now see, this is a patient with the 45 corneal opacity with an untreated subcapsular cataract, and then you can see this is a corneal opacity. So when you can see such type of opacity is there, and then behind you will see there is a cataract, and then you can say this is the opacity, then behind there is a cataract. Then what is to be done in such situations? Then we can see the cases where the normally you can see there is a problems in the you can say this cornea or results we always get in the problems, and this second thing you can see whenever you are doing you can say no, you can say any this anti-inflammatory drugs. So in this case we can't do that. And again you can see this corneal opacity with the superficial and deep, I can say ghost vessels are there, and so there are so many problems when you are operating with the ghost vessels. And so corneal sensation must be checked in every case of the corneal opacity when you are going ahead for this. And now see the small pterygium less than 3 mm not affecting the topography can be left alone or treated with the cataract simultaneously because that is not affecting. But a medium pterygium more than 3 mm affecting topography, pterygium to be treated prior to the cataract, because later on the toric or any IOL you are putting inside, so that may be a problem. So large pterygia can say 3 mm affecting visual axis should be treated with pterygium followed by the cataract surgery. Now see this spiral degeneration is there in the lower part, and now I am taking the incision in the superior part. You can see this is the superior cornea, and where I am taking the incision and just you see making the rexis here, and whenever you are making the rexis, then that opacity comes in between. So whenever you are start in the area where you can see. So in that area where you can see, don't start in that, and then lastly behind the opacity you can complete. So now you can see here while going in you cut, I always say that, and then I am rotating the nucleus. So that is the superior portion where I can see the cataract, and then this is a glide. Normally I use the Blumenthal technique, and you will see this is coming out from that area, and completed the surgery. You will see this, and then I am aspirating. This is the aspiration cannula, This is devised by us in 96. So we use this cannula, and then the lens is implanted and your surgery is complete only here. You will have to also repose the conjunctiva. Can you see, this is the very important step when you are doing the such type of cases. So here the you have seen how you can do the things. Now see here, it is a keratoplasty, and after that now I am doing the cataract. So now here again you will have to go behind where the sutures are not there, otherwise sutures will get ruptured, and then again you will have to take sutures there also. So here you will see the what I am doing is, whenever I am doing it, I am going behind and trying to see here. Now the sutures I have kept it, and after the sutures, the can you see this, I am doing the rexis. After the see here, the can you see, this is the, can see the rexis I am doing, larger behind the iris I am doing the rexis, and after that now I am separating the nucleus. So here why I am doing the, why not doing phaco? Because phaco may damage the you can endothelium of the your graft, and to avoid that I am doing the SICS here. You will see. So here the we can prevent the endothelium in such type of cases. You will see minimum damage to this. Then I aspirate the cortex, and once I aspirate the cortex, you can see here, and once it is, then the lens is implanted, where I want that the graft should remain clear and it should not be, can say, damaged. So I am doing for that. Then you will see, this is the 45 years patient, where you will see the corneal opacity, vascularization, you can't see glow. So in such situation, see, if there is no glow, then how you are going to operate? So now here you will see what we can do is, we can use the endo illuminator. So this endo illuminator is there, and you can see now the glow is seen. So this glow, now I have stained the capsule, and by the endo illuminator I am doing the can see the rexis extension is done. Here the phaco is not possible because you can't see anything, because opacity, can you see, it's very, very big opacity, vascular opacity all over. And what I am doing is, with the endo illuminator I am completing, and from, if you see from the front, nothing is seen, but only once there is a endo illuminator I can aspirate the cortex properly, also did rexis, and you can see the vessels are seen, opacity is seen, but because of endo illuminator I can see the glow. And with that, now you see, then again I will implant the lens in this. You see, again I will have to use every time the endo illuminator and aspiration. Few cortex were remaining, remaining, I have removed everything, and after that now I will implant the IOL. This glow will help me. See, this aspiration, I have removed the cortex, and now I am implanting. This is a foldable lens I have implanted inside. You can see the, and then I am dialing in the bag, because there is a bag. So we always think of the, yes, you can implant foldable lens in the this one, and in this case also, the, can you see, the centrally there is a small pupil open. Patient is having 6/36 vision. This is one-eyed patient, so we can't take any other chances. So with the conclusion, you will see the normally preoperative throat checkup is very, very required in the cases, such type of cases. Then the ocular surface disorders like with cataract needs the holistic management approach in that. And once you do that, cataract surgery should be optimized for every patient depending upon the extent of the corneal disease. So prior counseling about the, you can say, aggregation of the primary diseases, what aggravate ho sakta hai, you can get the corneal, you can say, opacity, or you can say keratitis sometimes, that you will have to tell the patient aggravate will be there. Otherwise patient will later on say, before that I was having the vision and after that my vision is reduced. So to avoid all these things, you will have to tell them properly, and importance of the follow-up here, because you don't know what is going to happen. So you'll have to tell them, come on next day, 7th day, 3 weeks, then 6 weeks, like that, and then you can follow up. Thank you very much.
Regarding pterygium more than 3 mm, you said treat pterygium and
First, because the astigmatism.
So regarding this vascularized cornea, what I feel is corneal opacity is because of vascularization.
Both, it means the first you get the corneal opacity, in that it is vascularized.
But you can cauterize, the opacity also gets.
No, if you cauterize also, that vessels will again come from the other place. So cautery is not the treatment of corneal vascularization.
Thank you so much for excellent talk. I have already explained so in such difficult cases, corneal opacity, how to visualize. So indoliometers definitely is it will be helpful to visualize even without microscope light. You can operate it. So have made the things very easy. Thank you very much for this inspiring these videos. And now I request yes, any comment, Dr. Ruchi?
Just one comment if you would permit.
Okay, Aris, yes.
You were talking about the vascularization. I think the genesis of vascularization would be somewhere, there is a limbal stem cell deficiency. So, so I think sir was talking in general, but that needs to be addressed, and that is not the end of the story. So if it is there, you must take care of your corneal release, maybe slits and all those would be the point. So basically what sir was trying to show was that with the endo illuminator you can do the cataract. You have to deal with the corneal opacity and the vascularization, but what he wanted to do was to show it as a two-step procedure, because doing a one-step procedure treating the corneal disease and the cataract as one time is not something he wanted to do. In this case what he wanted to show was the use of the endo illuminator to do a cataract surgery, which is made easier in the presence of a corneal opacity with vascularization. Sir, you can, sir, I think we are around 15 ophthalmologists and everybody has their own way of tackling it, because we have our own practices and medical colleges. So this is our way of doing it. Definitely there are other ways of doing it.
Whenever we all are experienced people. So everybody has got his way of doing. So if your way is different, then that is, I think we agree that what we do, that I am telling. So that is, IC is for that only, what we are doing, that I am telling. So you can have the different way of tackling, there is no problem. Okay.